Hello, we have a couple minutes before we get started and just thought I'd get on here. We'll see who's on. Hi, Michelle and Lori. It's nice to have you here. And so we'll just give people a few minutes to get on. And if you could type a 1 if you can see me and hear me, and if you can see my screen when I get to where I'm sharing it. All right. So I'm going to also share it to Facebook. So this will just take me a second. Excellent. There we go. Okay. Let me figure out. My screen share here. All right. So we should be good to go in a few minutes. So if you want to let me know where you're from, if you want to just type it in the comments or the Q&A, and we will go from there. We have a lot of people from the resilience-based psychotherapy group, and we have some people probably from a couple other sources, but that would be great. So Lori is from, I think CT is Connecticut. I'm hoping that's correct. I'm in Manitoba, Canada, so that's where quite a ways away. Yes, that is where that is from, where you are from. Okay, so it's 7:30, so I think we will just go ahead and get started. So we are streaming live to both Facebook in my group and also to Zoom. So the comments in Zoom are the ones that I go from most. It's hard to do it on both. So that's where I will do receive most of the comments. I will go back after and also respond to comments that are in the Facebook group. So we'll get that both ways. Since you're taking the time to be here, I just encourage you to shut off any notifications or anything that may distract you from doing this, and grab a pen and piece of paper and we'll dive in. So this is a free training for basically for my resilience-based psychotherapist group that it's information that I really only share with people that I'm doing coaching and consulting with. And now I'm going to share it in the group. So this will be a really good start. Today we're going to be talking about client resistance and the factors that are related to clients. Okay. So I already mentioned that before we get started, if you could get a pen and a piece of paper, we will do a Q&A at the end. So if you can post your comments and questions, I'll kind of give you a cue of when we'll be doing that. So I will be able to get to those questions and turn off all those distractions. So I mentioned before, my name is Dr. Barbara Woods. I am a psychotherapist in private practice in Manitoba, Canada. That is right above North Dakota. And yes, we had snow. We've had 3 days of snow on and off, but it's all melted today. So that's wonderful. Snow tires are on my vehicle. We're all ready to go. So I have specialized in treating children adolescents and adults for trauma and attachment disruptions. I've gone through several kind of permeations of my career where I've worked in substance abuse, corrections, a school psychologist for a First Nations community here in Manitoba, and now I own my own private practice. So resilience is just a really important part of my life and my work, and resistance, I think we can all agree that this is something that we all come up across when we're working with people. And it's very difficult to deal with sometimes. So this series, we're going to talk about today's resistant clients. On Wednesday, it's going to be family resistance. So when you're working with a whole family of people, how does that resistance come out? And it's a little bit different than working with just resistant clients, and what to do about it. And it's probably not what you're thinking. So let's get started. So today, when we're working with client resistance, you're going to learn the 4 elephants and 3 mice. You're going to learn client factors that contribute to resistance, and how does resistance show up in the therapy room. So it's really important for us to all understand that from a resilience-based approach, we have the understanding that resistance is resilience. It served a purpose previously, but it's no longer serving that purpose, and it's interfering in the present. So some of the things that people show up with in the therapy room are things that have protected them and kept them safe previously, but it interferes with the therapeutic relationship. So it's just important to know that that is the foundation and understanding of this, that it is actually resilience, and we have to kind of honor it and respect it that way, which sometimes is hard to do. If you're feeling that, type a 7 in the comments. I'm sure you've all had some resistance, and all kind of either it struck you after the fact, which are the mice, or it's like right there in your face, which are the elephants. So let's get to that. There's quite a few types of resistance. The elephants there's 4 types of elephants that we're going to be talking about. And these are the big things that show up in the therapy room, and they're very obvious. They're like glaring you in the face, and they're usually quite uncomfortable. The mice are more subtle and are mostly related to more internalizing disorders. So sometimes anxiety and depression. The resistance that those clients have are far different from clients who are mandated or who present with the resistance like the elephants. So elephants can come in all shapes and sizes. They are typically found when you are working with mandated populations. So sometimes substance abuse, corrections, sometimes court evaluations, all those kinds of things where somebody's referred to you and maybe doesn't want to be there or has had a bad experience in the past. And then the mice are more related to those internalizing disorders, anxiety, depression, trauma. So let's get started. Elephant number 1, this is just a downright arguing where the client isn't respecting the clinician's experience, training, or expertise. So they challenge the therapist, they challenge the interventions, they challenge your knowledge, they challenge every little thing, and there's never kind of a giving up. They never give any space in that. They question your authority or expertise, so they may be wondering who you are to be able to do this and what your knowledge actually is. They may do that a little bit more subtly, or they may do it kind of non-verbally with rolling the eyes or kind of giving some looks that are kind of arguing in a nonverbal manner. They can be overtly hostile too. So this is where you'll see some of the clients in corrections and substance abuse, where if you hit a nerve, you'll get an overtly hostile arguing response. Elephant number 2, the client defensively interrupts. So whenever you start to reframe something or move towards something or introduce an intervention, they don't wait for a pause for you, and they'll talk right over you. They interrupt because they probably have some unspoken sense of where you're going and what this is going to be about. So they talk over you to get the direction changed or to get it where you're kind of off track so that you can't continue that way. They also may just speak right over you, interrupt, and just kind of cut you off and not let you finish your thoughts. Elephant number 3 is when a client expresses an unwillingness to work together. So this unwillingness may not be very obvious. They may blame other people. So this may be a family comes in to work with you and they're blaming the social worker, they're blaming the school, they're blaming everybody, but not taking responsibility for the situation that they're in. They disagree with suggestions. So there's some clients where you can explain the intervention, the purpose for the intervention, why we're doing this intervention, and they disagree with everything. So this is a really difficult one where then you change your intervention up a little bit and reintroduce it and the purpose of it and how this would help them, and they disagree with that. And then you keep moving and pretty soon your whole toolkit is demolished because there's no more interventions to use. That is a definite sign of resistance, this elephant number 3. They can also make excuses for their behavior. So they just don't take responsibility. They may become late and it's always traffic or it's always something that is beyond their control that they don't have any responsibility for. They may minimize the situation. So if you're working with children in foster care, the biological parents or even sometimes foster parents may kind of minimize a situation where you're trying to get them to practice new parenting skills. And they're like, well, the temper tantrums aren't that bad, we'll just handle them. But they're really kind of minimizing it because they may not want to do the work. Pessimism and negativity can be a really difficult one to deal with. This can be part of depression. It can be part of anxiety. But this is where that pessimism and negativity really filters into the therapy setting and makes it really difficult to do your interventions with them and get not their consent, but really to get their engagement and their enthusiasm and get their buy-in to different interventions or things that you're suggesting. Some people come to therapy and they have no intention to change. So anything you try to suggest, they're not going to want to change it. So if you try to talk with them about making some changes in their lifestyle to maybe support cleaner living without drugs and alcohol, they'll come up with all kinds of excuses and they will not make that commitment to change. Parents do this too when you start asking them to do certain interventions or use strategies with kids as well. And the last elephant of the list is ignoring the therapist or not following conversations. So this is, you'll see this more in group settings or in different types. One-on-one, it's kind of hard to do this, but it can happen where they can't pay attention to you, or they just are kind of distracted and not focused. They don't respond to questions. You'll start the conversation traveling in one way and they'll change the direction completely and just kind of derail your intervention. So the mice come in with those internalizing disorders, or they're less obvious in the therapy session because it's not direct confrontation, arguing, that kind of thing. So the first mouse is related to therapy interventions and approach. So some people may have beliefs that that mindfulness is something that they shouldn't be practicing because it goes against their spiritual beliefs. So you can introduce this and they may be kind and be courteous, but they may just not engage in that type of intervention, but they won't tell you that, or they don't like your approach. Some therapists are very directive. Some are very client-centered. They may not like that approach. They may be seeking somebody to really develop a warm relationship with and just be able to come in and talk, and that's their perception of therapy. But when you try to do more structured things that are more directive, they kind of lose interest or do not engage anymore. The second mouse can be to in-session exercises, interventions, or structure. So if you're a pretty structured therapist that does a check-in, reviews homework, identifies something kind of small to teach, has a between session assignment, confirms that, and moves on, that structure may be too structured for some people. Likewise, if you don't have a lot of structure, it may, for some clients, it may feel like they're just kind of, there's no direction in therapy and they don't really know why they're there or what they're doing. The in-session exercises, it can just be something that just doesn't sit well with them and they really don't like it or don't, it just doesn't resonate with them. And interventions, they may not like, if you're telling them to practice mindfulness or relaxation and they're really stressed out, they may be like, this woman's like, what is she teaching me to be relaxed for? I'm so stressed out. We get it. They may not get it as easily as we understand our interventions. So mouse number 3 is even more subtle. This can be as small as using words, phrases, or concepts. So when we're in positions of psychotherapy, we work with people from a wide variety of backgrounds. We work with people with differences from ourselves. And sometimes these words, phrases, concepts that we use, if we use a lot of psychobabble, a lot of technical terms, they may really be turned off by that and may just kind of zone out or not be as engaged. So it's really important to kind of keep an eye on some of these elephants and the mice to see kind of what might be happening and if you can find a pattern in any of your clients or kind of comments that they make. So now we're going to look at client factors that contribute to resistance. And sometimes we do all feel like we're drowning in resistance. That's why I selected the photo for this background, because resistance can be very overwhelming. It can be overwhelming for new therapists, and it can be really overwhelming for therapists who are more mature in their careers or getting to a place of burnout and things like that. So some clients come to us and they have a huge fear of failure, or they have a lot of perfectionism. So if they're afraid that they're going to fail and you're asking them to do things, they may just resist, not do it, become silent because they're so afraid to fail that they don't want to do that and don't want to let you down, don't want to look like they've failed. And then perfectionism, we see this a lot with, we have an intervention called Mindfulness Integrated Cognitive Behavior Therapy. It requires using mindfulness twice a day, requires reading chapters of a book. It's a pretty intensive program. And you would think perfectionistic people would get it and do it and appreciate the structure because it's very clear what you do. But a lot of times when they don't do their meditations because they don't have a perfect 14 meditations to record and report on, that perfectionism kind of causes them to withdraw from either therapy or not want to do that approach just because they have this perfectionism. So this is something that we've started to really watch for with our clients and really drive it home that not doing between session assignments, not working on things is no reason not to come to therapy. That's in fact the time that you need to come to therapy. So we have to watch out for that fear of failure and perfectionism. We'll see perfectionism a lot more in some of the professional people that we see and people who have a lot of anxiety. Sometimes clients are just downright afraid of taking risks. So these risks can be as small as even being in a room with somebody that they don't know and having kind of this new relationship that in some ways it's not a regular social relationship, but then it's got social components to it with the boundaries of ethics. So some people are just fearful of taking that risk. They have things that they've experienced that they may have never told anybody. and they're so fearful of this. I had a young person when I worked in a correctional setting that he continually came to my office, wanted to be seen and wanted to be seen, but really wasn't doing anything. And I started to kind of wonder, like, does he have a hidden agenda? Like, what is going on here? But he wasn't a controversial inmate. He wasn't known for that kind of stuff. So I just kind of wrote it out, and I had a bookshelf in my office, and he came one day and he was really nervous, and he said, "I want that book on your shelf." And I was like, "Well, which book is that?" And he said, "The one with the purple writing." And it was The Courage to Heal. He had been a victim of sexual assault, is in a male correctional environment. That's not an easy place to take those risks. So he looked resistant because he wasn't working through things. He wasn't making a lot of self-disclosure. But he knew kind of what he needed, and he developed the courage later to be able to ask for that. So I packaged it up in an envelope, put 2 envelopes in it. I called the unit officer and said, "I'm sending him over with a book from our department. Can you please just let him in? If you need to search it, you need to do it privately." And the officer didn't even bother because it had come from my office. And he read it, he came back, interestingly, and when he brought it back to me, he just it was in the envelope, he just threw it to me and said, "Thank you." But then after that, I could tell there was a huge difference in him. So sometimes we have to ride out their resistance, but that's the fear of taking risks. And the all wonderful power, control, and manipulation. Sometimes clients naturally come by wanting to be in a position of power, needing to feel like they're in control, or wanting to manipulate the therapist. So we will see this more where people are involved in agencies or referral sources that could cause there could be some consequences if they don't follow through with therapy. So you think about substance abuse treatment and being mandated to that. Sometimes programs in corrections, families who are referred for assessments or for therapy due to child abuse or neglect. They may really want to have a high degree of control and may really want to manipulate the therapist so that nobody learns the family secrets or nothing happens and breaks their family up. So this is a more difficult one to work with because you may sense the power and control, but the manipulation is going to be much harder to pick up unless you've got kind of third-party sources that you've read a report, or you know what the history of drug or alcohol use is or criminal behavior, and then they're kind of not going there and not telling you the full story. Yes, clients can have passive-aggressive anger towards their therapist. And again, this is one that's really common when you're triangulated with an agency or somewhere where you have to do reports or you have to evaluate their progress. So if you have to evaluate their progress and they've made minimal progress, they may become quite angry, but they're not going to direct that towards you. So they're going to be quite passive aggressive. They may make kind of slight comments. They may just silently refuse to do what you're asking them to do. Passive aggressive anger can be a difficult one to deal with, but we'll look later at ways to deal with that. So a lot of us work with clients who have trauma and attachment disruptions, and by nature, trauma and attachment disruptions have significant shame along with them. And shame can drive behavior that looks like resistance, but it's shame. So that's part of what that young man was experiencing, the shame of being sexually abused and being in a male facility and wanting to work on that. The shame of having had an affair, the shame of not having disclosed abuse, all those kinds of things can be really strong and powerful driving forces in a client's life. So it's always important with a lot of clients to really keep this in the back of our minds, because they may not be resisting out of total power and control. Some of it may be that once you crack this open and you start to look at what's inside and what experience they've had, they may have to regulate and deal with a huge amount of shame that might be very difficult for them. Unhealthy dependence. So sometimes clients love their therapists and they don't want to get rid of us, or they don't want to get rid of what comes along with being in therapy. So I have had clients that are transported from about an hour away. They don't have transportation themselves, but they're transported into the city where I work, and then they're transported home. And sometimes they need that ride into town, so they don't want therapy to end because they need the ride into town, or they just like being a client. So they will, once they start making progress and it looks like therapy could end, something will happen and they'll come back. So it could be an unhealthy dependence. This happens more, it might be kind of a hidden agenda, or for a secondary gain, like a ride into town or attention that they get for being in therapy. I also worked at a female correctional institution, and it was so interesting that the women, a group of my clients, I didn't tell them they were my clients, but they knew they were. After the week was over, on Friday night, they would gather together. There was one that would lead a guided meditation, and then after the guided meditation, they do kind of a sharing circle and talk about what I talked with them about in their therapy session and what my recommendation was. And then if they had any questions or anything, they'd kind of say, well, what would Dr. Wood say about that? Or how would she approach that? And it was actually quite healthy. But it got to the point that having that group on a Friday evening made it so nobody wanted to get out of therapy, because then they wouldn't be in that group. So there can be dependence on the therapist or on secondary gain that comes along with being in therapy that causes them to not make a lot of progress. Our clients who have had a lot of chronic trauma and complex trauma, or have had a string of bad events happen in their lives, can actually become quite exhausted. And this is like a psychological exhaustion where asking somebody to add one more thing is just way too much. So we have to be careful when we are doing interventions and asking them to do things between sessions if they're psychologically exhausted. We might kind of need to work with them on learning skills to cope and relax and have that downtime rather than adding more stress to their mix. The instinctive response to change. This can be either a personality style where we're getting into possibly personality disorders, or it can just be when somebody's met with, you need to make a change in this way, they just get their hackles up and they do not want to do it. They'll come up with all kinds of excuses, but later on they'll kind of come around and it'll be okay. But you might kind of hit a wall with some people when you start asking them to make a change. Some people just like to argue and they find it intellectually stimulating. They like that it's related to the power and control, but they really like to just argue. They like to see if they can fluster you. And sometimes therapists are very good-hearted. They're very kind, that it's easy sometimes to get a therapist rattled if you're arguing with them, particularly if you're a newer therapist. So that intellectual stimulation of arguing can be a really difficult one to deal with. And there's interventions that can be used to deal with that, but that's another landmine that might be a little bit difficult to deal with. So how does resistance show up? It can show up by not doing what was agreed upon in session to do, not doing homework, not making the changes that you've asked them to make. So it might just be a lack of progress between sessions. can be missing sessions. So they may go where they miss. I find if you have a client that misses a string of sessions, or they call and they say, you know, that whole Marsha Brady, something just came up and I'm not going to be able to make it, but I'll call you back in a couple weeks. If that's at a point where you've just recommended an intervention or just changed focus, or something significant has shifted in therapy, and then they start missing a block of sessions and they put some distance in there, and you kind of know that there's something off, that this might be more resistance than truly having too much to do and being unable to make it to your office. They outwardly disagree with you. You'll see it show up there. I've had people where you like do all the work to set up an intervention, you've explained it, you've explained the purpose, the reason, you've broken it down into small parts, and then you say, okay, so then we're gonna like go to a coffee shop, not us together, but go to a coffee shop, stay there for 5 or 10 minutes, say hello to 2 or 3 people, and they're like, what's the use of that? That's nothing. That's not going to help me in any way. But their life is so constricted that they're not leaving the house. So when they outwardly disagree, you've hit kind of a resistance point. Even if you've explained the interventions, they say that they understand it, they're riding right along with you, and then all of a sudden they just disagree at the end. Getting only partial agreement in sessions, I could try that. I might be able to do it. They might only do part of what you've asked them to do between sessions, or they might kind of just give you half answers and not really be thoughtful in the process. So this one is really interesting. This one is related to trauma. It's also related to shame as well. So body language that indicates a fear of being hurt. So this would be kind of that thing like this, where they don't want to look at you, they don't want to, and sometimes they're kind of like this, and they have a really hard time making eye contact, being open, using the body language in a positive way. And this may indicate that they're really shameful or they're really afraid of being hurt. And I've had clients do this where they cannot look at you. They cannot, they just are so fearful of what's going to happen in therapy. And they may not really understand what therapy is about. But once you can relax that fear and let them experience that felt sense of safety, it's like taking the thorn out of the lion's paw, and they become very grateful and committed in therapy. So working through that fear of being hurt or shame is really important. Avoidance of topics and issues. So you bring something up that you've had kind of indicators that this might be a problem, maybe substance abuse, maybe if you're assessing if they're faithful in their relationship, if you are assessing if they've thought about divorce and they just flat out avoid it and won't talk about it, or if there's issues that they won't talk about. It is good if we can allow clients to have a certain degree of choice in not discussing things, because that's them having healthy boundaries in a relationship that's really quite different, and it's kind of social but not. So it's really good if we can allow a little bit of that, but if it becomes constantly and consistently over the course of several sessions, you know they're kind of avoiding a topic or an issue. So emotional distance or withdrawal, where things may have been going well and then all of a sudden they just they're emotionally distant, they won't talk. This happens a lot with teenagers, and this will happen when you have a third party that's involved, like a social worker, a parent, if you've given recommendations to a teacher, and the teacher then says, like, if you've said they need a quiet space to study, and if they get anxious or stressed, they need to leave the classroom, and the teacher then goes to the child and says, well, now I have to put a whole new program together for you because this is what she told me to do. So that child may start to put emotional distance or withdraw because of the dynamics of what happened around that situation. This happens a lot whenever you have a referral source or a third party involved where you're reporting or you're collaborating. So it's really important. It's really important for everyone to be on the same page, but sometimes the resistance shows up in the other referral sources or people that we collaborate with too. So it can also show up in subtle changes in the therapeutic energy that indicates disengagement. So this will be something like all of a sudden everything falls dead silent and nobody, like you're trying to pull things out of the person who's talked before and never had this difficulty, but it's just really really difficult. The energy just kind of dropped and you have no idea what happened. That can happen within a session if you've hit a sensitive point. It can also happen between sessions if they've had a reaction or thought about something that really was disturbing for them, or they've tried something that you've suggested they do, like talk with their spouse or partner, teacher, and it didn't go so well. They may just kind of emotionally disengage, or the therapeutic energy may change. So that is all I have on client resistance. We're going to go into the Q&A. So if you have any questions that you would like to have asked, you can type that in the Q&A spot. I'm going to try to check on Facebook and see if I can find any of those. I will stop my screen share, and there we are. So we have Amy and B and Corinne, Debbie, Evelyn, Heidi, hello, Jennifer, Lori, and Michelle all here. So that's great. Doesn't look, let me check one more spot for any questions. And it doesn't look like there's any on Facebook as well. So the topic for the next webinar is, it's on Wednesday evening, same time. It's on family resistance. So this is where the dynamics in families, how those may kind of be impacted and how it may appear to be resistance in the therapy room. So if you have any questions, if you are in my Facebook group, you can post those questions hopefully under this video, and I will be emailing the replay link to you guys so that you can have this to refer to. So I hope you have a beautiful day. And now I have to see if I can figure out how to stop this.